This video is going to be covering the second part of the brachial plexus. So for the first discussion about the second part of the brachial plexus, I just want to make sure we understand the components of a dermatome versus a peripheral nerve innervation. Okay, so a dermatome is an area of skin supplied by the dorsal root of a spinal nerve. I put this slide here to help us remember. A dermatome, so one more time, a dermatome is an area of skin supplied by the dorsal root. The dorsal root is right here. This is the sensory portion of a typical spinal nerve. The dorsal ramus will have both mixed and sensory, but the dorsal root is going to be the part of the nerve that supplies the cutaneous innervation at a specific spinal level. So each one of these spinal nerves has a specific nerve distribution. In the head and trunk, each segment is horizontally disposed, except for C1, which has no sensory component, only motor. So what you're looking at here is this kind of idea. It's C2, C3, C4, C5, right? They're working their way down, and then these are going to be the cranial nerves up front, right? I hope we can appreciate that. But you can see here C2, C3, C4, C5. So we just start making our way down. Dermatomes of the limbs from the fifth cervical to the first thoracic, and then in the lumbosacral plexus, are going to extend as series of bands from the midline of the trunk into the limbs. So you'll see that here. So 2, 3, 4, and then 5 is where we're going to start to really extend into the limbs. But you'll notice that C5, C6, C7, C8, T1, they keep this horizontal distribution. It's just now they're having to move down into the limbs. It's going to be the same thing at the legs. The legs are a little bit more complicated, and so I'll talk about those more in the lumbosacral plexus because our legs kind of are going to rotate as we develop. But these dermatomes, this segmental innervation is just going to extend its way down into the limbs. So again, the thing that I wanted to compare and contrast here is the idea of a dermatome versus a peripheral nerve innervation. So our sensory innervation to the skin can be described in two different ways. Our nerve roots, like what we just did, it corresponds into the 31 pairs of spinal nerves, right? Because we don't have C1. It's just C2 through S5. It's pretty segmental. It works its way down. However, the peripheral nerves, especially at the plexes, right, we're gonna have overlapping nerve roots which may supply a specific area of skin. So, and there's a few pictures of that coming up later. So dermatomes are representative of a generalized tract of a single nerve root. But peripheral nerves are made up of multiple nerve roots and usually innervate in a certain area on the body. And maybe I'll just cruise down here so you can see that. So for example, our lateral brachial cutaneous nerve, right, it's a branch after the axillary once it passes through the deltoid. It's going to be made up of multiple nerves or nerve roots. It's made up of multiple nerve roots which supplies an area of the body. Here's the radial nerve. Notice the radial nerve, how big this distribution is. And we know that the radial nerve has contributing portions from the posterior divisions of all three trunks. And so the radial nerve actually is going to contribute to many different portions of this. Okay, so that was the first thing that I wanted to bring up here, was this idea of dermatomes versus peripheral nerves. You'll see that there's a lot of overlap as we go through, but it is a distinct principle here. So now we're going to dive into some specific passages of the nerves, kind of where they run to. I'll try to give you guys a couple structures that they innervate. I hope you're learning those in lab though. And then we'll try to understand a little bit better the course of these nerves. So this is going to be our brachial plexus. The first thing that I wanted to just cover is the brachial plexus and its relationship with the scalenes. So the scalenes are going to be these muscles in the neck, and we'll cover those in the muscular unit of the upper extremity in the trunk. That brachial plexus is going to come out between the anterior and the middle scalene. It's going to be superior, so this is the subclavian artery. It's going to be superior to the subclavian artery as it comes out, but then they're going to be closely intertwined as they move on down. So again, that brachial plexus is going to come out in between the anterior and middle scalene. It's going to be above this major artery, and then they're going to run underneath the clavicle, which hopefully makes sense. I mean, one purpose of bones is some protection, and this is really one of the first places that we can receive some bony protection. So that brachial plexus is going to dive underneath that clavicle and then come on down the arm from there. Another view on that as it comes down. So we don't have the scalenes here, but this kind of gives you another view that we're going to dive underneath the clavicle, and then once we hit this lateral portion of the scapula and we start to get into the humerus, this is where we're going to have some further divisions. We're going to have our posterior cord that becomes our radial nerve come down the posterior side of the arm. We're going to have a division of our median and our ulnar nerve as it comes on down. So we're going to start to divide after that point, but our trunks, our divisions, and then into our cords are all going to be pretty superior or proximal, if I can use that term here, on the brachial plexus. Here's another picture of that brachial plexus. We have many of those throughout here, just as a reminder. So the first nerve that I'm going to really hit on here is going to be the musculocutaneous. Musculocutaneous is going to be coming from the lateral cord. It's the superiormost portion of our drawing of the brachial plexus. So the musculocutaneous is going to be coming up here from our lateral cord, and then it's going to dive off and it's going to come and innervate muscles really quickly up here as part of the brachium. So biceps brachii, coracobrachialis, part of the brachialis muscle, it's going to come off and be very quick into those muscles. Not much else to say about the musculocutaneous. I might say a few more things in class. So now we're going to get into the radial nerve. So the proximal radial nerve, the radial nerve is so big and it's going to receive innervations from all of these via the posterior divisions. So we're going to divide it into a proximal and a distal portion. So the proximal portion is going to come off. The first parts of that innervation are going to be our C6 and C7 up here, and it's going to come and dive in, and the first place it's going to go is going to be into the triceps, and then we're going to have some cutaneous innervation via the posterior brachial cutaneous nerve up here through the tricep region. That radial nerve is going to run right through that radial groove of the humerus. So I'll point out throughout this lecture a couple places. We're going to call these perilous points of passage. So places where a nerve might become injured if someone sustains a type of injury to that place. So the first perilous point of passage here that I'm going to introduce is the radial groove of the humerus as the radial nerve runs through that. It's a place where the radial nerve might become injured if we have a bony injury at that radial groove. So now we're going to move on down. So as we move down, that radial nerve innervation is going to move down a little bit. So now we're talking about the distal radius. So we keep coming down, and now hopefully based on your brachial plexus drawing, you're starting to think, okay, as that radial nerve comes down, we're going to have our posterior brachial cutaneous, but as we come down, we should now start to have a division of the deep radial, the superficial radial, and the posterior antebrachial cutaneous. So that deep radial is going to come and innervate all of these wrist muscles, all of the posterior wrist muscles. If it has the name extensor in it, it will be innervated by the radial nerve. That superficial radial is going to be preserved, so it can come and do some innervation here on the hand, specifically some cutaneous innervation. And then the posterior antebrachial cutaneous will be supplying the skin region of this posterior antebrachium. So I'm going to throw in a couple tidbits here, and I will talk more about this, but I want you to begin to think. So at this distal radius portion, if we have, so for example, if we have a fracture and it injures the radius, here, If it injures the radius here, so the tricep has already been innervated. But if that injury happens just right here, as we come down, what are going to be the musculoskeletal problems as a result of this nerve injury? So the thing that I hope you're beginning to think, well, if that deep radial innervates all of these extensor muscles, if we lose that nerve, we're going to get what is called the wrist drop, where we can't actually pull the wrist into extension, but it will constantly be in wrist flexion. Okay, so take a second and just think about that and see if it begins to make sense in your mind. Moving on into the median nerve, there's going to be a couple places where that median nerve has a perilous point of passage. One is going to be right here in the cubital fossa. Another is going to be in the carpal tunnel, and we'll talk a little bit more about both of those. So the median nerve is going to be coming down. The median nerve arose from our medial and lateral contributions of the lateral and medial cord to the median. So we are going to have some ventral rami innervation to different points of the median nerve as it comes down. The median nerve is going to innervate this part of the hand, and then it's going to innervate most of the muscles of the forearm. Most of them, not the flexor carpi ulnaris, but most of the muscles of the forearm are going to be innervated by the median nerve, and then we're going to have a small portion of the hand, the thenar eminence, which is going to be right over here, which will be innervated by the median nerve. So again, I want you guys to be thinking as I kind of go through. So let's say we have an anterior dislocation of the elbow, or we have some type of an entrapment here of the median nerve as it passes through the pronator teres. What type of pathology is likely to result? We're likely going to have decreased amount or strength of wrist flexion. We're going to have decreased amount of strength of wrist flexion because our ulnar nerve will also contribute to our flexor digitorum profundus and our flexor carpi ulnaris. So will we lose wrist flexion entirely? Not likely, because we have other parts of our body that can help contribute to that. But we're going to have decreased wrist flexion strength. Now I want to move into the carpal tunnel, because carpal tunnel syndrome is such a common condition. It's likely that you know somebody who has carpal tunnel syndrome. So at this flexor retinaculum of the wrist, we're going to have a bunch of structures that are encased by the carpal bones and the flexor retinaculum here. So you can see that this is a fairly tight space. So any type of entrapment, so if we start to experience some tendinitis, where these tendons start to inflame, if we wear a bracelet or a watch or something that is incredibly tight and it restricts the amount of space that happens in this carpal tunnel, we're going to have some compression on the median nerve. And if we have compression on the median nerve, then we're going to have some corresponding symptoms down into the hand. So this next image I'm going to show you is called ape hand, and if someone has sustained carpal tunnel syndrome with compression on that median nerve, and they lose the ability to actively contract this thenar eminence, you can imagine how if we don't use those muscles, they're going to atrophy. There's a good word, atrophy. Those muscles are not going to get nourishment, and they're not going to have growth, without growth. So you can see here in this person's left hand, they have a nice thenar eminence, typical of someone that uses their thumb. But here on their right hand, it's apparent that they have some type of a carpal tunnel syndrome, which has compressed their median nerve for an extended period of time, which has then led to muscle atrophy of the thenar eminence. So this is a musculoskeletal problem that can arise from the median nerve having a problem. Okay, so here we are, ape hand. I'll talk a little bit more about bishop's hand in class. Bishop's hand and benediction hand, those are kind of the same thing. So, but this ape hand has a nice picture there. Okay, we're plowing ahead here. So now we're into the ulnar nerve. Ulnar nerve is going to come specifically from this medial cord. Now we're moving down into this medial part of the forearm, and medial part of the hand down here into the fourth and fifth digit. Okay, so we're talking ulnar nerve as it traverses down here. So ulnar nerve is going to come from that medial cord. It's going to go posterior to our medial epicondyle of the humerus, which is a cubital tunnel. So it's going to go posterior to that. It's going to come down. It's going to run directly underneath that flexor carpi ulnaris, which it innervates. It's also going to innervate a portion of the flexor digitorum profundus. And then I like to think that that ulnar nerve is actually being specifically preserved because it is going to come down and innervate most of the hand here, most of the hand. It's going to pass through a structure. The pisiform is going to make this structure right here, Gaillon. I think he's a French guy. Gaillon's canal or Gaillon's tunnel. So that's kind of the course of the ulnar nerve with some perilous points of passage at the cubital tunnel and Gaillon's canal. Here is that ulnar nerve as it traverses. This is a posterior view here. We can see some extensor muscles, right? It's going to come posterior to our medial epicondyle. Okay, the ulnar groove is a nice bony structure that you probably remember. If you sit there and tap on the posterior part of your medial epicondyle of the humerus, if you tap on it hard enough, you might begin to experience some numbness and tingling as it extends down into the arm or into the hand. So that's you kind of irritating or compressing that ulnar nerve. Let's keep going here. So like I mentioned, this ulnar nerve is going to come and be preserved for most of the digits of the hand. It's going to supply some skin innervation here at the portion of the fifth or portion of the fourth and fifth digit. All of the hand intrinsics. Median nerve is going to come and pass through the carpal tunnel, and it's going to innervate the thenar eminence and then cutaneously a portion of the hand. So here's another image on that. Ulnar nerve here, median nerve here. Radial nerve, that superficial radial nerve specifically, is going to come and catch this posterior part of the hand opposite of the median nerve. So just a couple more slides here. So first, we're into these perilous points of passage. So this is a single slide which helps sum up many of the perilous points of passage that we might find for each of our different nerves. Okay, so for the axillary nerve, we have a perilous points of passage as it wraps around the surgical neck of the humerus. Radial nerve, I already just mentioned that radial groove of the humerus is going to be a perilous point of passage for the radial nerve. Another place where the radial nerve might become compressed, they call this a crutch nerve. If someone has crutches and they're compressing up into their axilla, there's a chance that they might actually compress that radial nerve, resulting in some weakness of the triceps and weakness of the wrist extensors. So that would be like a crutch nerve. Coming on down, so we've got our median nerve right here, right at that cubital fossa. Any type of fracture right there, a dislocation of the humerus or of the elbow might potentially impact that median nerve. Here's our ulnar nerve coming down, that posterior portion of the medial epicondyle of the humerus. If you have some type of a fracture there, if you have some type of a compression, if you bang it really hard, you've probably felt that shooting pain down into your hand. Our deep radial nerve is going to potentially have a perilous point of passage here as it wraps around the radius and then goes and innervates all of those wrist extensor muscles. Moving down, median nerve at that carpal tunnel. And then finally, our ulnar nerve at this tunnel of Gaillon is going to be a perilous point of passage. So the recurrent or median, don't sweat this one too much. We're not going to splice this out too much. But anyway, yes. So there is an additional one there. Okay, so one more time, I just want to rehash this idea of segmental innervation versus peripheral nerve innervation. So here is a dermatome map. Hopefully now you're appreciating that this corresponds to segmental innervation. So C2, C3, C4, C5, we start to expand down into the arm. C7 is the middle finger, C8, and then T1, and then after T1 we get back into segmental innervation through the core, and then once we hit down into the lumbosacral area, now we're going to start wrapping around the leg again until we get back to the anus or the those final sacral nerves, and these are going to then again be segmentally innervated. So each of our segmental levels, as scientists have researched this, have discovered that we actually have a little bit of overlap between the dermatomes. So, if we say that this is actually let's say this is a thoracic level, T2, T3, T4. At each of these levels, T2, T3, T4 right there, we're going to have about a half of a dermatome overlap. So if we were to lose T3 right here, we may still have some cutaneous innervation due to T1 and T3 overlapping that area. Now we're back to our peripheral nerve cutaneous innervation. So you'll notice here that we don't have our nice striped lesions through the arm, but rather we're going to be innervated by specific nerves, and these are the ones that you guys are beginning to think about. For example, our medial antebrachial cutaneous nerve, our medial brachial cutaneous nerve, our lateral brachial cutaneous nerve, our lateral antebrachial cutaneous nerve. In the hand, ulnar, median, radial is going to make up this backside. Notice the posterior antebrachial cutaneous nerve. These are peripheral nerves innervated in an area that likely have a couple of nerve levels innervating each region. And this is another view on that. We are going to cover some myotomes in class. So hopefully you hung with me through most of that. Take some time, go through these slides. We'll try to hit them a little bit more in class. My hope here is that you watch this and get some initial exposure to these, that we can come to class with the questions we have and spend the time in the areas that we need to. And that finishes this video on the second part of the brachial plexus.